Merhabalar. Merhabalar.
Tabii.
Bu öğleden sonra, güzel öğleden sonra hepiniz hoş geldiniz. Bugünkü konuğumuz Mazdi Alizade. Bize aile hekimliğinde kanser önlemede özellikle aile hekimliğinin rolünü anlatmaya çalışacak. Kendisi çok değerli bir konuğumuz. Önceden beri katılıyor sağ olsun bizi hiç yalnız bırakmıyor. Welcome. Mazdi, how are you?
Thank you. Fine. First of all, I would like to thank you, all of my friends there, especially Dr. Ersin and Dr. Serpil and other chairs, Dr. Ahmet Yonder and Dr. Erdem Birgul.
Before your speech, I want to introduce my colleagues
okay,
also,
sure.
okay? Mazdi Alizade, Tebriz Sağlık Bilimleri Üniversitesi'nde çalışmakta. Kendisi aynı zamanda halk sağlığı üzerine de master'ı mevcut. Community Medicine uzmanı. Onun dışında da yine aile hekimliği ana bilim dalında ana bilim dalı başkanı. Bizim diğer konuklarımız da diğer chair'larımız diyelim, başkanlarımız da yine Erdem Birgul, kendisi çok değerli ve uzman bir arkadaşımız. Aile hekimliğinin duayenlerinden İstanbul'dan katılıyor. Ben bu arada Serpil Demirag, Aydın'dan katılıyorum. Herkese merhabalar tekrar. Ve Ahmet Yonder arkadaşımız da yine Adana'dan katılıyor. Hepiniz hoş geldiniz. Ben de teşekkür ederek başlamak istiyorum. Daha sonra Mazdi'ye söz vereceğim. Ersin ve ekibi mükemmel bir iş yapıyorlar. Yıllardır bu işi çok güzel bir şekilde kotarıyorlar. Bu yılda bizi yine sempozyumsuz bırakmadılar. Çok teşekkür ediyorum kendilerine. Bizi de davet ettikleri için. Diğer başkanlarımız herhangi bir şey söylemek isterler mi? Mazdi'nin konuşmasından önce.
Hocam teşekkür ederiz. Ben de gerçekten Ersin hocama ve ekibine bize böyle bir fırsat verdiği için teşekkür ederim. Ben birinci basamakta bir fiil çalışıyorum. Aile hekimiyim. Vefa Aile Sağlığı Merkezi'nde Seyhan'da. Sayın Mazdi hocamıza hoş geldiniz diyorum. İyi bir sunum yapmasını temenni ederim. Teşekkür ederim.
Teşekkürler. Erdem Hocam.
Evet, ben de çok teşekkür ediyorum yine bu mükemmel toplantı sürecini devam ettirdiği için Ersin hocamıza ve arkadaşlarına. Konuğumuza da hem hoş geldin diyor hem iyi bir sunum diliyorum. Çok teşekkürler.
Çok teşekkür ederiz. Evet, Mazdi'ye sözü bırakmak istiyorum. Welcome Mazdi again. Let's see your presentation. Thank you.
Now I want to share my screen before starting the presentation. Hi everybody. Thank you for inviting me to this year's Congress, and I'm pleased to be with you once again. And I really appreciate Dr. Ersin for this invitation. And I also want to express my deepest gratitude to the chair of this session, Dr. Serpil, Demirag, Dr. Erdem Birgul, and Dr. Ahmet Yonder. Thank you, everyone. First of all, I would like to share some of my previous years' memories as with my good friends that I met in these 2 or 3 years when I was with you each year. And I never forget the friendship I met in this Congress. Thank you very much, and I would like to start my presentation with with mentioning the importance of incidence of cancer in the world. As you know, we in 2018 we have 18.1 million cases of cancer worldwide, new cases of cancer worldwide. And it is predicted that in 2040, the number of new cases of cancer will be 29.5 million. This is the increasing number of new cases in all over the world. At the same time, we have some reasons for improving the continuity of care of cancer patients. These are the causes of this issue. First of all, as you know, life expectancy is increasing year by year in most of the countries. Because of the old population, and also the increasing the number of old people in the community. And on the other hand, with increasing the life expectancy, we have so many new cases of cancers. At the same time, the survivor of cancer is increasing. The people with cancer will survive more than past because of the modern diagnostic equipment, the early diagnosis, and the very effective treatments for cancer. And also because of the survivorship, because of the being alive after treatment, there will be so many comorbid conditions for cancer patients. These are some causes that we need a continuity of care for these patients. But in most of the literature and the ideas of some of the patients are that the patients think that they don't need to see their primary care physician, and that the oncologist should treat everything. This is what some of the patients think, and we are going to review some different articles and different views about the role of family physician in cancer care team. There are different models for cancer care team. This is one of the models that we have medical oncologists, surgical oncologists, radiation oncologists, we have pharmacists, we have social worker, other specialty provider, and also the primary care physician. The other one, this one, is another model of a cancer care team with physicians providing oncology care, maybe oncologists, and clinicians providing psychosocial support and spiritual workers, palliative care clinicians, for example, in hospice, rehabilitation clinicians, physician assistants, pharmacists, and also nurses. You cannot see here the family physician or primary care physician, but it is in one of these circles. For example, clinicians providing psychosocial support. Maybe one of the person in this team is family physician. Let's have a rapid review of the roles of each of these people in the team. Most of us know the role of oncologist and oncology nurse to diagnose, to confirm the diagnosis of the cancer, and to prescribe the medication, and to give the medication, and to care the patient. Another person that is very important, I think, but we don't have it in Iran. I don't know if you have such a person in Turkey or not, is patient navigator. I think it's very important for cancer patients. The individual guides people from diagnosis through survivorship. Here in Iran, when somebody diagnosed with cancer, and after referring to oncologist or a radiotherapist, after that, she or he is wondering and doesn't know what to do. So we need someone here, maybe in your country, I don't know, someone called patient navigator to help to consult the patients and to help to resolve the financial problems. We try to have some non-governmental organizations here to train them to do such a role, but they are not successful here. Some people, some articles mention that family physician can do some of these tasks, but I think it's not the only task of family physician. Palliative care doctors and nurses, they work closely with other oncology team members, and they prevent the side effects of treatment, and also they treat the side effects of the treatment. And in some articles, in some associations like American Academy of Family Physician, there are some points in the family physician curriculum that they can handle the side effects of cancer treatments. But in most of the countries, there are some palliative care doctors to do that. And there's a social worker oncologist that help the social issues, for example, financial issues, and also providing some resources for patients. Pathologist, he or she gives the final diagnosis of cancer, and working directly with oncologists during the course of the disease to show the effectiveness of treatment and the size of tumor during the treatment, and so on. There's another person in the team, rehabilitation therapists, or such as physical therapists, occupational therapists, speech therapists, or recreational therapists. These are people that help patients to return to their highest level of functioning. For example, they can help people with brain tumors regain speech and being independent, or help people with breast cancer learn to regain the strength of their muscles after mastectomy, or other, or when people have complete bed rest after treatment, they help to regain the muscle strength, and other therapies. There are people called hospice care specialists. There are doctors, there are a team, doctors, nurses, healthcare professionals, social workers, some religious people, counselors, and maybe there are some volunteers, trained volunteers, and they work with family and also with patients. A patient that is at the end of life and no longer an active treatment is working for him or her, and this is the last days of her or his life. And also the other person in the team is pain specialist. It could be a doctor, an anesthesiologist, a nurse, and or a pharmacist who are expert in pain control. And we have pharmacists he or she is going to make sure that treatment and medicines prescribed to patients are safe and effective. The last but not the least in this list is family physician. As we reviewed the other people's roles, you see each of them has a clear task and role. But when we think of the roles and tasks of family physician in a cancer care team, we cannot find a clear role for him or her, because most of the articles give the roles of family physician to other people, to other healthcare professionals. But Now we are going to review some articles and some text about the role of family physician in different countries here, and at the end we are going to reach to a conclusion about the roles of family physician in this team. This is the cancer continuum. And these are what we are doing for a cancer patient or if a person without cancer at the first line. First of all is cancer prevention and cancer screening. As you know, these are most of family physicians do some of their schedule on cancer prevention and cancer screening, and I'm going to talk about it later more. And then cancer diagnosis, cancer treatment, that the outcome of cancer treatment would be palliation or end-of-life care, and also maybe the other path is survivorship or rehabilitation. And the end is maybe bereavement, and this is the course of a cancer patient, what we do for a cancer patient. And where is family physician here? What do family physicians do in cancer team based on this continuum? As you know, health education and lifestyle modification is one of our important tasks in our clinic. Something like smoking cessation, like physical activity, like obesity, and alcohol control, and other lifestyle modifications. Cancer screening is another part of our daily activity as family physicians. We have guidelines for family physicians for cancer screening and for preventive medicine specialists. They are doing it every day, and for people in different ages and sex. Cancer diagnosis with maybe some more sensitive and more specific diagnostic tools. It is one of the roles of family physician to confirm the first diagnosis in screening. And when diagnosis is confirmed, the family physician should refer the patient to a good specialist, to the specialist, for example, oncologist or other specialists or subspecialists. And then when treatment of cancer patient is begun, maybe some side effects is going to be shown, and the family physician should deal with side effects during therapy. What is I myself add to this list is some of my researches and my works on social prescribing based on some experiences in UK. Social prescribing, I don't know, maybe 2 years ago, I don't remember, maybe I mentioned it in one of the your conferences. Social prescribing is one of the most important tasks of family physician, not in cancer, but in most of the disease, the chronic diseases. For this, the family physician should get the social history and give the social diagnosis. I mean, the socioeconomic status of the person and the environmental hazards of the patient, where the patient is living, and what is the hazards, what is the risk factors of the environment she or he is living, and the financial issues. And then the family physician can find a link between patient and other societies or NGOs that help the patient in these social issues. Or maybe there are some social workers or link workers that link the patient to different resources to get help for some psychosocial issues and also environmental and recreational issues. This is the other task of family physicians, social prescribing. Most of us that are engaged in curriculum development of family medicine, we know the list of competencies of family physicians. Some of them are these: continuity of care. This is the most famous competency of family physician. Multi-generational relationships that allow a family physician to guide a patient and family through the referral process. And also unique knowledge of the patient's values, family issues, and also communication styles. These are very, very important competencies and characteristics of a family physician that make he or she an important person in cancer care team. As you know, family physicians practice according to the 4 principles of family medicine that are: the family physician is a skilled clinician, 1. The second is family medicine is a community-based discipline. The third one is the family physician is a resource to a defined practice population. And the fourth is the patient-physician relationship is central to the role of the family physician. These are an introduction that I'm going to emphasize on because I want to prove that the family physician is an important person in cancer care team because of these skills and these competencies. But what is going on in reality? Family physicians and oncologists often differ in their perceptions of the role of family physician in cancer care. There are a lot of studies that asked family physicians and oncologists and the views of them about the role of family physicians in cancer care team. And I'm going to review some of them to clarify these differences. In a study, a survey of 3,596 family physicians and oncologists in USA, 59 to 75% of family physicians agreed or strongly agreed that family physician is able to provide follow-up care and detect recurrences. But oncologists are not the same. Just 23 to 38% of 23 and 38% of oncologists believe that family physician can do follow-up of cancer patients and also detect recurrences. And this is the difference between family physician and oncologist. And another survey that was done in USA with 255 family physicians and 123 oncologists showed that 57% of family physicians said follow-up care was mainly or fully the responsibility of family physician. And 30% stated that both family physician and oncologists should fulfill this role. These were the views of family physicians. But on the other hand, 0% of oncologists believe that family physician could be, the follow-up care is the responsibility of family physician. And just 2% of oncologists believe that the family physician and oncologist can fulfill their roles. So this is a huge difference between family physician and oncologist. Another survey in Canada showed on 232 family physicians that and 45 cancer specialist oncologists and 395 cancer patients. This study found that a significantly higher proportion of family physicians and patients expect family physician to participate in cancer care during diagnosis and treatment. But the oncologist, most of the oncologists didn't believe this. But these three groups, patients, family physicians, and oncologists, all of them believe that in the advanced and terminal stages, a high proportion of all of these groups believe that it's the role of family physician and it's now the time of involvement of family physician when at terminal stages of disease. Among all these groups, more than 80% of participants said they expected family physician to provide emotional support in all stages. In some countries that I reviewed the articles about the role of family physician, especially in Canada, in UK, in some Scandinavian countries, most of them, most of the patients believed, and also oncologists believe that family physicians should have an emotional support role for cancer patients in all the way. Another study was a qualitative study among surgical oncologists and dermatologists. That they said that the main responsibility for follow-up care was the responsibility of the specialists. But they think that family physicians are important, especially for anxious patients. And they work as an additional person to contact that they provide reassurance for patients and address patients' psychosocial needs. So these are some ideas about the role of family physician in different countries. As I mentioned before, in some countries that family physician has a known role, like Canada and UK, they think that family physician is good for anxious patients, and their task is to respond to psychosocial needs of the patients. What are patients' views? In some studies, patients unfortunately rated their family physician's ability to manage medical problems that are related to their tumors treatment as low. But they think that their family physician is good for emotional support, not to resolve the medical problems of the treatment. He's not good at it. This is what some of the patients in different countries mentioned. In some studies, I mentioned all the studies at the bottom of the page, In some studies, cancer patients consult their family physicians on treatment decisions, and particularly the decision to terminate treatment. They also arrange appointments with their family physician to review consultation with their oncologist. After visiting the oncologist, they come back again to their family physician to consult more. And patients value their family physician because they can ask him or her different questions on cancer than their oncologist, because family physician have maybe have more time and know his or her patient and his or her family, and maybe more empathetic to him or her. And they feel considered as a whole person. It was a good expression here. Family physicians provide reassurance and emotional support and diminish fears of being alone with the disease. These are some views of patients about their family physician and cancer care. The idea that the family physician is a person of trust was based upon their knowledge of the medical history and family situation of their patients, as well as the duration of their relationships with patients. So most of family physicians know their patients, their families, and for a long time because of the situation of family physician and also the continuity of care. Some studies mentioned about the family physicians' opportunities and risks in the view of oncologists. Oncologists believe that family physicians' they are able to deal with anxious patients. And oncologists believe that family physician can explain the patient about the oncology treatments and about the oncologist's decision, and to have a good, because they have a good relationship with patient. And oncologists think that family physicians can support the oncologist's decision because of this relationship. And also they think that family physician can provide information for oncologist's treatment decision or treatment termination because of this continuity of care. On the other hand, what are the risks of family physician in cancer care team in the view of oncologists? These risks that are oncologists thinks that family physicians are not up to date in cancer diagnosis and cancer treatments. And also sometimes some family physicians may threaten the patient-oncologist relationship. Maybe they make challenging the oncologist treatment decision, and maybe other things. These are what oncologists think about the risks of family physician in cancer care team. But some studies also have shown that family physicians are capable of providing quality cancer care, especially during diagnosis, follow-up, and palliative care phases. These are the articles that discuss about this issue. I just selected some of these articles that were important. One of these articles was, or two of these articles were two multi-center randomized controlled trials of breast cancer patients. These articles found that follow-up care provided by family physician was safe and also an acceptable alternative to specialist follow-up care. And it's good news. Barriers that limit the role of family physicians in cancer care team. I was talking about barriers that limit the role of family physician in cancer care team. I talked about the communication problems. I talked about the clarifying the role of a family physician in cancer care team, and the lack of adequate training for family physician about the cancer treatment side effects, and also other issues in cancer care, being an effective person in cancer care team, and some system issues, that there's no network for cancer care in some countries that clarify the role of a family physician in this network. And most of the family physicians think that they are not, the other people in the team don't share the information about the patients with them, and not being copied on all medical reports for their patients. These were the barriers that limit the family physicians in some countries and in some reports. Many family physicians describe their feeling that most of the time they feel that they are being bypassed once patients had entered the cancer system. Or, for example, those participants in one of the studies, phrases such as swallowed up by the cancer system. Their patients are swallowed up by the cancer system, and they have no access to their patients anymore. Or the black hole of the cancer clinic that attract the patient, and they cannot have any access again to their patients. Or they said that I lost my patient to cancer services. These are other views of family physicians about the cancer care team and cancer care system in some countries. But three patterns of care with increasing level of family physician involvement is suggested. First one is a sequential pattern of care, that with virtually no family physician involvement and patients receiving most of their care from the oncology team. This is that we can see in most of the countries, maybe in my country. The other one is parallel, with the family physician will still involved, but mainly for non-cancer problems. For example, comorbidities and some psychosocial issues. But the third one is shared pattern, that it's with involvement of both the family physician and the oncology team in cancer care. These are sequential, parallel, and shared three patterns of family physician involvement in cancer care team. But good news are that some researchers indicated that outcomes related to cancer recurrences is the same between family physician care and oncologist care. These are the results of some of these regardless of follow-up care arrangements. Serious clinical events are both extremely rare and equal in frequency in family physician care and in oncologist care. Or another study for post-surgical colon cancer patients, that some of them assigned to family physician care and some of them assigned to surgeon-led care. The follow-up, there was no difference between group in quality of care or depression or anxieties. These clinical trials are very important. That shows that there's no difference between the care of family physician and oncologist. I found an article in Turkey about changes in cancer control palliative and from it was shows the views of family physicians about the role of family physician and their how much of their daily work is assigned for different levels of cancer patients. Most of the family physician mentioned that more than 60% of their activity was about health education of cancer prevention, and more than 60% of their daily work about cancer was on screening. But after diagnosis, it's less than 50% of the activities of a family physician in Turkey is on the care is the same as and some other countries in this area. In this article, family physicians in that province in Turkey mentioned that the challenges of their work as a team in cancer care after diagnosis was not being any no communication between family physician and specialists. The communication problem was the same with other studies in other countries, and also they said that there's not any electronic data system that would allow primary, secondary, and tertiary care providers to share data with one another on cancer care, on cancer patients. At the end, I'd like to introduce you some resources about cancer care for patients after diagnosis of cancer, especially. These are good resources. One for Royal College of General Practitioners in UK. It's a good website, Primary Care Cancer Toolkit. You can find so many guidelines for patients after diagnosis and, for example, oncologic emergencies, how to recognize it and how to manage it as a family physician. You can find some guidelines here. And also, there are some recommendations for practice with evidence ratings and with referencing, for example, palliative care consultation and other recommendations for practice for family physicians after cancer diagnosis. For example, this is a part of a guideline about the oncologic emergencies for family physicians. What should they do in each, for example, in tumor lysis syndrome, in hypercalcemia of malignancy, or some hematologic side effects, structural side effects. What should they do, and what are the roles of family physician in managing these side effects? The other good resource is from the American Academy of Family Physicians. You can find in this site the primary care of the patient with cancer. There are some good resources and some good guidelines. For example, this one is primary care of the patient with cancer. Key recommendation for practice with evidence rating. For example, treat chemotherapy-related nausea and vomiting with 5-hydroxytryptamine antagonist, and manage chemotherapy-related anemia with apatin alpha, and so on. These resources are very good for using as resources for treating patients after diagnosis. And this one is Cancer Care Ontario. This is recommended resources for primary care providers. This website has good resources and guidelines and toolkits for family physicians for cancer care. So it's time to summarize and to ideas and what is the main ideas and what is the summary of this lecture. What are the roles of family physician in cancer care team? First of all, lifestyle modification, prevention, cancer screening, and diagnosis are the most important and most common roles for everybody to prevent cancer. And then after diagnosing the cancer, treatment of side effects during therapy, such as sepsis, neutropenic sepsis, fever and neutropenia, metastatic spinal cord compression. We can, as family physicians, we can manage these side effects. Social prescribing, as I mentioned in my lecture about the role of family physician for social supporting of the patient and psychosocial supporting of patient, and to have link with some NGOs and other organizations for social support of patient. Shared follow-up, survivorship care, end-of-life care in some issues, and flexible mediator between the patient and the clinic. A family physician can be an interpreter or sometimes a translator, because as you know, most of the subspecialists maybe cannot have time or even training to talk more with patient and get more time for patients. Some references mention that family physician is a handyman solving practical problems locally and personal companion for the patient through the illness, someone that gives reassurance to patients and also emotional support. Thank you very much for your attention, and if there is any question, I'm ready to answer. Thank you for for the time that you have given to me, and thank you the very, very respectful chair that helped me to give this lecture. Thank you very much.
Thank you so much, Masti. This was very useful, and I have learned lots of things. Thank you so much. I hope to see you physically again in healthier days. And I want to leave my speech to the other chairs. Please go on. Thank you so much.
Sayın Hocama teşekkür ediyorum ben de. Biz de Türkiye olarak Dünya Sağlık Örgütü'nün önermiş olduğu özellikle 3 kanser üzerine taraması üzerine Sağlık Bakanlığı'nın birinci basamak temsilcileri olarak hem kadınlarda kendi kendine meme muayenesi, 2 yılda bir mamografi, yine 30-65 yaş arasındaki kadınlarımıza simir ve HPV DNA taramalarını, ayrıca 50 ve 70 yaş arasındaki tüm bireylere de gaytada gizli kan bakıyoruz. Kolon kanseri açısından 2 yılda bir de kolonoskopi öneriyoruz. Biz bunu birinci basamakta tüm aile sağlığı çalışanlarımızla birlikte imkanı olan yerler bu numuneleri kendileri alıyorlar. Diğer yerlerde ise sağlıklı hayat merkezleri aracılığıyla biz bu testleri kendi vatandaşlarımıza, daha doğrusu istekli olanlara yapıyoruz ve bunu da taramalarda büyük başarı elde ettiğimizi düşünüyorum. Siz kendi ülkenizde özellikle gaytada gizli kan, bizim ülkemizde vatandaş biz kiti veriyoruz, kendisi yapıyor evinde. Evinde kendisi yapıyor. Sizin ülkenizde bu taramaların etkin olduğuna inanıyor musunuz? Bu şekilde mi yapılıyor? Teşekkür ederim.
Thank you very much. I don't know if I get your comments completely or not, but I think you mentioned the tasks of the family physician in your country, that the most task of your family physician is screening, breast cancer, mammography, and self-assessment, and also the colon cancer, blood in the stool, and also the other one is HPV vaccination. These are, I think, the screening programs of cancers for family physicians there. Your question was about the screening of colon
what's the
cancer.
situation in your country?
Yeah,
Screening programs.
Screening program is an integrated program for non-communicable disease in our health network, that our family physician in our health system do that based on a national guideline. For example, for breast cancer, for we have some tests, rapid tests in the clinic, in health center. I think you said that you give the kit to the patient, yes? But we don't give it to the patient. We have it in health centers, and also these three. We don't have HPV vaccination here. Just some educations, pap smears, and also some referral for mammography, and some health education for self-examination of the breasts. I think it's like your country. But my question is about the role of family physician after diagnosis the cancer. Is there any program, integrated program for family physician in your system? Because we don't have anything like this. Just our the task of family physician in our country is before the diagnosis, screening and health education and lifestyle modification. What is like in your country?
Ahmet Hocam, anlatmak ister misiniz? Özellikle daha sonrasındaki görevini soruyoruz.
Türkçe anlıyorum ben. Türkçe anlıyorum, but konuşabilmiyorum.
Teşekkür ederim. Teşekkür ederim. Hocam anladım. Çoğunu anlamak istediğim şeyi anladım. Kendilerinin klinikte yaptığını ve o şekilde.
Evet. Size şeyi soruyor Mahasti. Daha çok sonrasında ne yapıyorsunuz? Yani kanser tanısı aldıktan sonra hastalarda özellikle
sonrasında eğer pozitif
diye soruyor.
Hocam kişi kanser tanısını eğer pozitif çıktığında gayet de özellikle meme kanserinin gönderdiğimiz kişiler bize pozitif çıktığında biz bunları ilgili genel cerrahi uzmanlığa yönlendiriyoruz. Seçilmiş genel cerrahi uzmanları var hastanelerde. Bunlardan randevusunu alıp onlara yönlendiriyoruz. Daha sonra onlar bize takipte işte 3 ay, 6 ay ne kadar takipçi varsa biz de kendisine yapılan işlemleri buradan takip ediyoruz. Kendisini bilgilendiriyoruz. Yaptığımız işlem bu. Meme kanserler için söylüyorum bunu. Ama özellikle kolon kanserlerinde ise kişi kendisi testini yapıp geldi. İşte pozitif çıktığını düşündüklerinde yine aynı şekilde yönlendiriyoruz hocam. Ve takiplerini düzenli bir şekilde daha sık yapıyoruz. Onların eğer pozitif çıkmışsa mutlaka ve mutlaka tekrarını ve takibini sık yapıyoruz hocam.
Okay.
Erdem hocam sesi kapalı zannedersem sesi kapalı.
Erdem hocam size söylemek istediğiniz bir şey var mı?
Thank you, Professor. Very informative presentation. Thank you for that. We accept our cancer patients as one of our chronic disease patients for the current time. So we deal with them for a long time. The problem with communication with the oncologists is a fact. And one of the things we want to propose for their education, they should have some training to be able to understand the conditions of the care physician, and can be done together for all sides of the care of the cancer patient. I hope we can achieve it someday. Thank you very much.
Thank you. Thank you very much.
And I want to add one resource also. NCI, the division of NIH, is a main resource, is one of the main resources for the cancer care, I guess. Do you agree or no? I don't know.
NICE, yeah, nice,
NCI,
you mean?
National Cancer Institute.
Yes.
Yeah.
Yes, National Cancer, NCI, yes,
Yeah,
yes.
NCI.
Yes, it's very good resource for family physicians also. Thank you for reminding me.
Okay. Thank you so much. Evet, süremizin sonuna geldik. Hepinize bizi izlediğiniz için çok teşekkür ediyorum. Yüz yüze de görüşmek dileğiyle diye kapatıyoruz. Hoşçakalın. Goodbye.
Hoşçakalın.
Bye. Thank you very much. Thank you. Bye.
Hocam. Hocam teşekkürler. Görüşmek üzere.
Teşekkürler. Thank you. Hope to see you again face by face next year.
I hope so too.
No problem.
Yeah.